Oral health relates to how healthy the mouth is, including lips, tongue, teeth and gums. It enables individuals to perform essential functions such as eating, breathing and speaking without pain and discomfort. It is integral to our general health and well-being. Most oral health diseases can be prevented or managed by healthy behaviours such as enjoying a healthy, balanced diet and cleaning teeth and gums effectively. Poor oral health has a negative impact on our general health and well-being. It can cause pain and discomfort, hinder our ability to speak and smile, prevent enjoyment of eating, cause dehydration through poor intake, impact our dignity and confidence, increase our risk of infection, cause reduced healing, and increase our risk to general health, as poor oral health is associated with other health conditions such as diabetes and pneumonia. More than half of older adults who live in care homes have tooth decay, compared to 40% of over 75s who don't live in care homes. Due to advances in dental care, people now keep their natural teeth for longer, but this can mean they need more complex dental care than people who have dentures. Long-term conditions can limit older people's ability to carry out their usual activities of daily living, which may impact on their oral health routine. This can leave older people at higher risk of both cavities, dental caries, and gum disease or periodontal disease. Many medicines reduce the amount of saliva produced and leave people with a dry mouth. Thorough assessments and support from skilled and knowledgeable staff can help prevent infection, pain and health problems that poor oral health can cause. The mouth contains millions of bacteria. In the absence of regular mouth care, these bacteria will multiply and cause oral diseases that have an effect on the rest of the body. Oral bacteria are the cause of two of the most common dental diseases, tooth decay and gum disease. Tooth decay is associated with frequent sugar consumption. A lack of oral hygiene allows the bacteria to metabolize the sugar in the mouth, producing acid that causes cavities in the teeth over time. Gum disease is caused by a lack of toothbrushing or ineffective toothbrushing, leading to bacteria in the mouth creating a sticky layer over the teeth called plaque. Plaque is a white sticky substance that develops on teeth and causes inflammation of the gums, but it can be easily removed by brushing and flossing the teeth and gums twice a day. Gum disease has two stages. Gingivitis is the early stage of gum disease and causes bleeding gums. Periodontitis is the second stage, and this affects the bone supporting the teeth. Oral bacteria or toxins produced by bacteria can be absorbed into the bloodstream and travel to other parts of the body. People with gum disease have more bacteria in their mouths and may therefore be more likely to get infections such as chest infections. Strong evidence shows that there are some conditions and infections which may be caused or made worse by poor oral health, such as heart disease, diabetes and pneumonia. There is strong evidence linking gum disease and heart disease. Bacteria is absorbed into the bloodstream via inflamed gums, which travels to other parts of the body. This is thought to contribute to inflammation or tiny clots forming in blood vessels and leading to cardiovascular disease. There is also strong evidence linking gum disease and diabetes via a two-way link. Gum disease can lead to poor blood sugar control, and poorly controlled diabetes can lead to gum disease. People with diabetes are more at risk from developing other oral health conditions such as dry mouth and oral thrush. Aspiration pneumonia is a type of pneumonia that's caused by bacteria entering the lungs and causing a severe infection. The bacteria usually enters the lungs when we accidentally breathe in foods, fluid or saliva. In 2016, the National Institute for Health and Care Excellence, or NICE, published guidance NG48, Oral Health for Adults in Care Homes. This guidance required social care settings to have provisions in place to protect their service users' oral health. Both the NG48 and the NICE 2017 Quality Standard 151 QS 151 state that social care settings should ensure that an oral health policy is in place and protects residents' oral health. A nominated person who is qualified to carry out oral health assessments. The oral health assessment is carried out as soon as possible on admission to the setting. All staff have received oral health training, including how to report oral health care concerns and when to seek dental care. Each service user has an oral health assessment and it is in their individual care plan. a care plan is in place so staff can provide residents with their daily mouth care needs. Daily records of mouth care provided. This should include if someone refuses and what action the setting has taken as a result. Recording the action in a daily mouth care chart can help check that the plan is working and up to date. In 2019, CQC published the Smiling Matters report, which was a review of how well the NICE guidance NG48 had been implemented since its introduction in 2016. The findings from the 100 care homes that inspected showed that oral health was still not a priority and people were not always able to access the dental care they needed. The report made 6 recommendations, 4 of which were applicable to adult social care. 1. People who use services, their families and carers need to be made more aware of the importance of oral care. 2. Care home services need to make awareness and implementation of NICE guideline NG48 a priority. 3. Care home staff need better training in oral care. 4. The dental profession needs improved guidance on how to treat people in care homes. 5. Dental provision and commissioning needs to improve to meet the needs of people in care homes. 6. NICE guideline NG48 needs to be used more in regulatory and commissioning assessments. A member of staff trained in oral health assessment should assess the service user on admission. The whole mouth should be looked at, including its structures, how clean it looks and whether there is any pain in the oral cavity. A healthy mouth should be clean, be moist with saliva, have pink gums, tongue and cheeks, have teeth free of plaque and decay, have clean dentures which fit well, have no broken fillings, have no broken teeth or dentures, and have no mouth ulcers. If you notice an ulcer which does not heal after 3 weeks, refer the service user to the GP and the dentist. All residents should have an oral health assessment when they move into the care home, with the result recorded into their care plan. Care staff should start by asking the following questions. How do you usually manage your daily mouth care and what help would you like? What dental aids do you currently use? For example, manual or electric toothbrush, mouthwash or floss? Do you have dentures, and if so, are they marked with your name? If not, would you like them to be marked? Denture marking kits are available to buy online. When did you last see a dentist and who did you see? If you don't have a dentist, would you like help to find one? Do you smoke? Smokers find it more difficult to fight off gum disease. Smoking cessation should be offered to those service users who smoke or vape. Do you have any pain in your mouth? Using a pain scale is a good way of identifying how much their oral health is impacting on their activities of daily living, especially for those service users who find it difficult to communicate verbally. Care staff need to know when to reassess the oral health of a resident and how to support residents with their daily mouth care to brush their natural teeth at least twice a day with fluoride toothpaste, use their choice of cleaning products for dentures, clean their dentures, brushing, removing food debris, removing dentures overnight, use their choice of toothbrush, either manual or electric battery powered, and mouth care products. Care staff need to know that poor diets are associated with an increased risk of dental conditions, carry out oral health assessments for residents who stop eating or drinking, check for reasons making it uncomfortable, understand how dental pain or a mouth infection can affect a resident's general health, well-being and behaviour, and to know who to ask for advice, how and when to report any concerns about a resident's oral health, and how changes in a person's condition might affect their ability to manage their mouth care. When assessing the service user's mouth, think about the actions that need to be taken to improve their oral health and overall general health using the acronym SMILE. Consider if any of the below factors could be impacting on their oral health. S is for saliva, M is for mouth care, I for infection, L for loose teeth or dentures, and E for eat.